Good afternoon. Welcome to today's webinar, The Post-Millennial Transition Blues, provided through a collaboration between the Pennsylvania Medical Home Initiative, which is a program at the Pennsylvania chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health. We're appreciative to be partnering with the Epilepsy Association of Western and Central Pennsylvania, who have a mission to provide education and supportive services to individuals and families affected by epilepsy and seizure disorders. Representatives from the Epilepsy Association of Western and Central Pennsylvania who are joining us today include Greg McConnell, who is the Regional Coordinator, Jordan Hines, their new Initiative Coordinator, and Gretchen Knob, the Regional Director. This spring and summer, they are coordinating some wonderful conferences focused on transition for youth living with epilepsy. Please be sure to contact them for details if you're interested. This webinar, which will be given by Dr. Jonathan Fletcher, aims to gain an understanding and discuss the attitudes and roles of emerging young adulthood across generations. And it also seeks to help us understand the barriers to transition faced by youth and their families whose educational trajectory is disrupted during this process. And also for us to discuss best practices for engaging emerging young adults and preparing them for transition to college and work. We are pleased that Megan Mormel, who is a senior nursing student at Carleton University in Pittsburgh, is joining Dr. Fletcher today. As a 5-year member of the Youth Research Advisory Board, Division of Adolescent and Young Adult Medicine at the Children's Hospital of Pittsburgh of UPMC, she co-authored an article in the peer-reviewed American Journal of Bioethics. Megan lives with a chronic illness and successfully navigated transition to and through college. My name is Dr. Renee Turchi, and I'm a pediatrician at St. Christopher's Hospital for Children and Medical Director of the Pennsylvania Medical Home Initiative at the Pennsylvania chapter of the American Academy of Pediatrics. This webinar is being recorded. The recording will be available on both the Pennsylvania Medical Home Initiative and posted on the University of Pittsburgh Internet-Based Studies and Education and Research website. For CME purposes, please be advised that none of the speakers today have any disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views nor the policies of the Pennsylvania chapter of the American Academy of Pediatrics or its funders. Now please allow me to introduce Dr. Jonathan Fletcher. Dr. Fletcher is a pediatrician and adolescent medicine specialist and the Director of Medical Services at Princeton University since 2015. After completing pediatric and subspecialty training at the Children's Hospital of Philadelphia, he served as the Clinical Director for the Division of Adolescent Medicine. While at CHOP, Dr. Fletcher oversaw the creation of the Adolescent Medicine Clinic and the rapid expansion of inpatient and outpatient clinical services. He also collaborated in the creation of the Community Pediatrics and Adjunct Program for pediatric residents, one of the first and fully integrated curricula to focus on child advocacy and community health in the country. More recently, he was the Clinical Director for the Division of Adolescent and Young Medicine at the Children's Hospital of Pittsburgh of UPMC, overseeing the development of programs supporting the transition to adulthood for youth with complex needs. Dr. Fletcher has co-written original research articles in the area of adolescent vaccination, women's health care, and the transition from adolescent to adulthood. Throughout his professional life, he has led the development of comprehensive and accessible clinical programs to meet the needs of diverse populations by engaging and responding to the youth being served. Dr. Fletcher is the husband of Brooke, a pediatric primary care nurse practitioner, and the father of 3 young men. We are delighted to have Dr. Fletcher present on this timely and important topic for primary care clinicians. Dr. Fletcher, at this time, please begin your presentation. Thank you.
Thank you, Dr. Turchi. That's a very generous introduction, and it truly is an honor to be on this webinar and presenting to everybody who was able to join in. In addition to Dr. Turchi, I want to thank Eileen Thompson from the Pennsylvania Medical Home Initiative, as well as Greg McConnell, Gretchen Knob, and Jordan Hines from the Epilepsy Association of Western and Central Pennsylvania for coordinating and having the idea for this webinar and inviting me. So as Dr. Turchi described, the objectives for the webinar today are really to look at societal attitudes and roles of emerging young adulthood through a generational lens. And so when we're talking about emerging young adulthoods, we're really encompassing the age group of older adolescents, roughly around 16, up through around the age of 24 to 25. So certainly a time of immense transition. In focusing on this population of emerging young adults, we really seek to understand the barriers to transition for faced by subgroups within this population whose educational trajectory has been disrupted. And we'll certainly talk through all of the complicated factors that might affect that and who it impacts. And then finally, we'll discuss some of the best practices that have been emerging for engaging young adults and preparing in their preparation for transitions to college and work life. And in this regard, I'll be very much looking forward to handing off the talk to Megan Marmol to get the perspective of someone who's walking the walk. A few words on change. Transition is all about change, and this is something that's been the focus of philosophy and planning for thousands of years. Lao Tzu, if you don't change direction, you may end up where you're heading. I think we have applied that principle many times, particularly in our quality improvement efforts. It's a principle that's been around for a long time, more recently framed by Tony Robbins in a motivational speech around change is inevitable. Of course, progress is optional. And at the founding of our country, Benjamin Franklin, when you're finished changing, you're finished, to a more recent General Eric Shinseki, if you don't like change, you'll like irrelevance even less. And I hope to underscore many of these points as we continue to seek to understand the impact of change, particularly on emerging young adults. So again, we're talking about generally folks who are 18 to 26 years old. A shorthand definition, and this certainly does not encompass the entire population, but a shorthand definition, and this is a very modern definition, it wasn't always this way, but typically young adults are defined as not quite yet having children, not owning a home, and not having steady income. And that in and of itself comes through a certain generational perspective, which we'll talk more about. We do understand now that this is a discrete period of human development, and that it's a critical time period for brain development, and certainly establishing more complex ways of making decisions, and also being able to understand life from different perspectives, certainly necessary for engaging in very complicated societies. We also know by following demographics that this is in the United States of America, that this age group is an increasing percentage of the population over time. And we certainly know, and this has been underscored in the most recent elections, that this group does vote. So in thinking about it as a discrete developmental stage, we really base this understanding on neurophysiologic changes that can be measured, that can be seen, specifically around the prefrontal cortex that results in improved skills around complicated decision making. This also involves improving skills and competencies around emotional regulation and the inhibitory response that we often see adolescents struggle with becomes more in place during young adulthood. Over time, society has shifted in terms of how it's viewed and really needed this age group to function within society. And so they've been less likely to reach what might be called the traditional milestones, as I mentioned before, owning a home, getting married. And we also understand in terms of looking at the economic trajectory of our population that increasingly the need to be in training in school, both at the graduate level, undergraduate, and graduate level, is becoming increasingly important to maintain a career, to maintain employment. And so there is a transition that this age group is going through over time around what it means to be employed and what it means to be in school and balancing debt and responsibility. So often when we think of developmental stages, certainly within pediatrics, we think about the tasks or what is it that defines that developmental stage and that we look for in monitoring change. And monitoring is development happening to the best outcome for the individual. And certainly during young adulthood, we look for the application and refinement of coping skills. Stress is certainly something that's constant, and the type of stress, the quality of stress, the volume of stress, I think most people will agree increases over time, but certainly our ability to deal with it should outpace that ideally. During this time of development, most folks are developing a vocational direction that certainly may change over time. It's not established for life, but certainly some of the early educational goals and opportunities are defined by this early vocational direction. And of course, gaining work experience and school skills can happen in all kinds of ways during this time period, and we'll talk more about that. Relative to social relationships, This is the time of life where more long-term and mutually beneficial relationships begin to be established, and folks have multiple contexts in which they exist. They may have a work context, a school context, a family context, their engagement in the community, and so on. We'll also talk a little bit about identity as well as we move forward. At the core of all of these developmental tasks are the development and the formation of structures, thought structures for making decisions, and really rooted in value systems and in beliefs. And again, over time, we're learning more and more about how the human brain interprets information, how it values information, and the lenses through which we determine whether something is helpful to us or not helpful to us. So again, in engaging the complex world, it's often very, very difficult to even know what's a fact and what is not a fact. And so during this time, it is important to make choices, to make mistakes, and then to come back and do some critical self-reflection, hopefully with feedback from others. And during this time, it's an important time to develop an appreciation for the diversity of thought and perspectives as you're learning from different people with different experiences. And again, this begins to form and enhance pro-social values and belief systems. The next slide, this just indicates a bit of a timeline, just to give folks a chance to wrap their minds around what we're talking about specifically in terms of transition and how it relates specifically to healthcare. One of the populations of young adults with special needs is defined as a youth with chronic health conditions, also perhaps physical or behavioral health disabilities or learning disabilities, or mental health problems. And so typically there's a time of diagnosis, and then there's the way that special need would affect the life course, the trajectory of the life course over time. You know, somewhere around the 21st, 22nd birthday is when most folks decide it's time to move from the pediatric to the adult-oriented medical system. Again, there's lots of variation. Sometimes it's as young as 18. I've even seen as young as 16. And I've seen it extend up to age 26. But there are differences between those systems quite clearly. And not only transitioning the primary care provider is a transfer that happens, there also may be multiple transfers of specialists and other types of care providers. So that entire process, the process we refer to as transition, and within transition, there's likely to be multiple transfers and changes. And so how does this impact healthcare access? And the data has been very, very clear for a very long time that emerging young adults, that is our citizens from 18 to 26 years old, face some of the greatest barriers to accessing healthcare for several reasons. This plays out in terms of having the lowest utilization of preventive health visits, and also having the highest emergency department and urgent care utilization. We have seen some changes since implementation of the Affordable Care Act and the extension of health insurance up to age 26, but they continue to be the lowest utilizers of preventive health care. And how does this apply to some of the advances, many advances we've seen in healthcare and outcomes over the last several decades? Just looking at the group of young people affected by cancer, survival rates have improved over time for young adults, but certainly not as much as they have for younger and older age groups. And again, we're learning more about why that is and how to address that disparity. Emerging young adults are generally, typically thought of as a healthy population, right? We think of infants and toddlers and children as vulnerable because of the rapid development and susceptibility to environmental toxins and other factors. And we think of certainly of aging and the elderly as a time of vulnerability, but we often don't think of emerging young adulthood in that way, when in fact the highest rates of motor vehicle accidents, of substance use, of sexually transmitted infections, and a myriad of behavioral health problems really peak during this time period. It is the median age of onset for many chronic mental health disorders. And again, this is tied into the neurophysiologic changes that I talked about earlier. Including the onset of anxiety disorders, schizophrenia, substance abuse disorders, and more. Over time, we've been seeing increasing rates of diagnosis of obesity, autism, that will affect the life course, certainly, both in many ways. And over time we're seeing that there's an increasing proportion, now nearly a third or so, with a diagnosis of a chronic illness or a physical disability. And so what we see over time during in this period of development are that because of these barriers to healthcare, they disproportionately affect subpopulations within this larger group of emerging young adults. And so this slide is an application of life course theory to begin thinking about how this plays out through a health equity lens. We know from life course theory that there's a timeline, that each event is influenced by prior experiences and events over time. And so in this way, childhood trauma, even prenatal exposures, can play a huge role in how health plays out during emerging young adulthood. There is a cumulative impact of these events and of stress, and so that a weathering effect happens or toxic stress may occur. And again, that will result in different health outcomes depending on the resources and the stress that the young adult is exposed to. And again, a lot of this is rooted in environment. And so we do see inequities. We do see an uneven distribution of adverse life events, of environmental toxins and supports. We do see inequities and opportunities to improve health across several subpopulations of young adults. And so we think about diversity, equity, inclusion altogether, as we know that attitudes around this is shaped by lifelong learning. It's about exposure, it's about experience. And we also know that support for diversity, equity, inclusion does correlate to innovation, to free inquiry, to the discovery of new knowledge and new ideas. It's inherent to education. And that certainly equally as important is developing a sense of community and belonging where everybody belongs, and that would promote and support ongoing civic engagement and ethical leadership. We are seeing dramatic changes across generations, and specifically in this age group around diversity, equity, and inclusion. We certainly see over the larger, we'll talk about the generations as most people think about them, baby boomers and millennials and so on, but we also see smaller changes within the generations over time. As key events happen that affect the larger population, that then triggers change. And certainly you can see how this would reflect the role of these shared lived experiences and how the values and beliefs are being shaped. And certainly within generations, the diversity and the appreciation for diversity that exists within each generation also correlates to changes in attitudes. So, I focused in looking for data around this at the Pew Research Center that for many years has been defining generations and offering questionnaires and surveys to look at attitudes and changing attitudes across time. And they do address the question of, perhaps the change that we're seeing across generation is because as people age, attitudes change. And so what they've been able to do is actually compare data of Generation X when they were young adults, to millennials when they were young adults, to baby boomers when they were young adults. And so you are comparing young adults to young adults. This is a summary slide just comparing some of the data that's available at the Pew Research Center and some of the questions that they ask and how the dramatic change that we're seeing across young adults of these different generations. So the idea that immigrants strengthen our country, if you're a millennial, you're far more likely, much more likely, almost twice as likely to endorse that idea as someone from the greatest or the silent generation. The idea and accepting the data and the fact that discrimination is a primary barrier to success for blacks in the workforce is something that's much more widely understood. More than half of millennials understand that, whereas other generations are still struggling with that. And you correlate that, and it's certainly not a coincidence that those attitudes inversely correlate to the percent of the population that's white. In other words, increasing the racial and ethnic diversity correlates to better attitudes around difference. I wanted to highlight this slide. This is a demonstration of how an event can trigger change. This is from our son, Andrew, from the March for Our Lives, March 24th, 2018. And there you see a whole lot of emerging young adults speaking. So looking at today, looking through this intergenerational lens, what does it mean to be a young adult? We see that boomers today, they do favor traditional roles in terms of adult marriage, children, home ownership, and a job, not only a job, but a career, something that provides benefits and that can support a family. And you can see how these ideas align with institutions and how they assume and anticipate that there'll be opportunities, that there'll be economic opportunities to support that family. Whereas the millennials tend to favor more personal qualities, more self-driven, self-motivated, what is going to give me meaning and going to sustain me throughout my career and my life. And so taking responsibility for decisions, developing diverse and meaningful relationships, and looking for meaning in work are priorities for millennials. And certainly that may be reflective of distrust for institutions and the economic realities that the economic opportunities that existed in the past do not exist any longer. And again, there are many more diverse pathways to adulthood today that are accepted than there have been in the past. And so in thinking about who is most vulnerable, defining vulnerability by who faces the most barriers to health care, there have been defined seven groups that have been studied over time and looked at, and I list them here. And primarily I want to talk about these because of the issues that cut across these groups. What do these groups all have in common? And of course, one of the things they all have in common is disrupted educational trajectories. And we know that disrupting your education anywhere along life is going to affect your prospects, your career prospects, as well as affect your health-related quality of life across the life course. And certainly, we see within these groups that these are not monolithic groups, that you can't look at any one a group of young adults with special health care needs or who are in foster care and say that they all have the same needs. There's a high degree of neurologic diversity within these groups, and we'll talk a little bit about why that may be. And certainly these groups are inequities in societal supports and expectations regarding the transition to adult roles. I think most folks are well aware, and there's been national legislation passed to address this, that many children who don't have the benefit of parents or a steady home were expected to become adults magically at the age of 18. And now we're seeing over time slowly more supports being built in for young adults to make that transition as the larger population benefits from. And so over time, vulnerable populations you see are less likely to have a stable job, a home, or a family while adulthood. So you see how these disparities play out over time. The intersectionality is that no individual sees themselves as being in a special population or seeing themselves fitting into the special education bucket or the foster care bucket. But the intersectionality occurs because all of the people are dependent on the same systems, be those educational systems, juvenile justice systems, and so on. And so taking a systems approach to addressing this, often you can look across these groups and see what they have in common to determine what are the policies and the practices that might best benefit them. And if the goal is to address the disparities and to reduce inequities, then we need to think about how do we address the learning and physical differences that exist within these groups? How do we anticipate that? How do we value that? How do we anticipate that individuals are going to be affected throughout their childhood, perhaps, by things like parental substance use, parental learning problems, and some of the impact of the parents' childhood experience? And certainly, anybody who may identify in one of these groups has been subject to discrimination based on one of the isms, which I've listed below. And so really at the core of this, and what we're working to get away from, is the assumption or the belief that white male ethnic background, heterosexual, is the norm, is what people should strive for. And actually it's quite, and well, that only leads to one place, that leads to racism and genderism and heterosexism and so on. But really we should be valuing diversity that moves away from this perspective, and that will empower everybody. How does this play out in real life? How does this play out across young adulthood? Well, all of us, I think, probably wouldn't be on this call if we hadn't seen the impact of the school-to-prison pipeline, for example. We know this is a major problem faces school country to school. We know that there are populations of youth that are disproportionately excluded from school, both the primary and secondary level. This may be based because of physical accommodation needs, because of time spent away from school, because taking care of physical health. There could emerge behavioral health problems, or perhaps that might be primary that leads to time away from school and disrupted education. And it greatly increases, once a young person is out of school, the chance that they will be arrested and be in the juvenile justice system increases dramatically. And once in the juvenile justice system, the impact that that has on opportunities for post-secondary education and job opportunities have been well documented. And so we do see this pipeline of youth who've been excluded from primary school who end up in the adult justice system. So take a pause for a second and think about what can we do as leaders in healthcare, as deliverers of healthcare, as parents, as individuals who are young adults and agents of change. What are some ideas and what are some ways we can approach this? And so these are, what I want to talk about next are a few guiding principles, some ideas that can be applied as people are making decisions around policies and around programs to think about how can these principles be valued and central. So certainly we know that our systems of healthcare delivery, our systems of basically any service delivery are incredibly complex. And so the more we can create pathways for collaboration across services, we will much better be able to serve emerging young adults who are new to these systems. Even when you're not new to these systems, it can be very, very frustrating. And it's not new, there should be a shared purpose towards the youth-centered outcomes, and we should look to reduce silos where there's competition for resources between, for example, social service agencies or between divisions in a hospital and so on. We must engage youth. We must engage youth both in determining what questions need to be asked and determining what is the data that's the most important for planning and helping us interpret that data and translate it into programs. And so engaging youth and allies of youth in planning is extremely important. And particular emphasis, trying to engage youth who are excluded. Who in the population, as you define your population that you're serving, who is it that isn't accessing the service, and how can you reach them and learn from them about why that is? It can be quite amazing what you find out. Additional guiding principles for change include anticipating that human development is continuous. Transition is a very normal and natural thing. It should not be a surprise to anyone. And so how does this play out in healthcare? The more support we can provide for continuous relationships and a continuous relationship that is transferred through a warm transfer and through some overlap of the transfer with healthcare professionals has been identified as something that is very, very helpful in establishing ongoing care in adult healthcare systems. And so certainly if we want youth to come into our preventive healthcare settings and engage in these longitudinal relationships, we have to have office policies, we have to have practices that engage youth when they are finding new ways to, for example, travel. They're learning about the ins and outs of insurance and what terms like deductibles and copays mean. They're learning about the nuances of managing struggling to manage a schedule with multiple demands of work and education and healthcare. And so again, we need to anticipate this and plan for it and embrace it. And at the professional level, certainly continual professional education, staff development, and nourishment that drives patient-centered outcomes, that keeps the focus on what can we do to better serve and that we find meaning in serving our patients. So fostering professional development that leads to collaboration, to self-care and compassion, finding joy and meaning in work, and embracing this across discipline and establishing specific competencies that support young adult development. So that's the theory. So what we're trying to find the sweet spot, right? We're finding the sweet spot for service delivery for emerging young adults. here are some specific examples of things that I have found and many others have found to be incredibly helpful at improving the patient experience. And this may play out on satisfaction surveys. This is played out in utilization. One of the big things are late patient policies. Being told no is something that we all struggle with, and particularly if we're being told no about something that we really need, that can be difficult. And when we're told no, when it's something that we've struggled for and we've overcome several barriers for, that could really just be a non-starter and might lead to someone not coming back ever again. And so certainly when a patient is late, anticipating that young adults are going to be late, building schedules around that, and creating a system that ensures that their immediate needs are heard and addressed if possible, and that a plan is made for follow-up, can be extraordinarily helpful. That is much more effective than policies that are based on the principle of they need to learn, and the only way they're going to learn is to be turned away. That does not work. Certainly, we need to look at ways of reducing clinic wait times, or perhaps also making those wait times more utilitarian for the young adults by creating waiting spaces that might engage them through social media and other ways. And certainly utilizing interdisciplinary strengths, again, this team-based approach can really help immensely with patient flow. Creating an inclusive and welcoming environment for young adults can only be done with young adults. And so that is also incredibly important. And having the scheduling processes that are flexible and that anticipate that there is going to be a demand for walk-in or immediate services and create some leeway for that also can be helpful for when young adults feel they are in crisis. So the long and short of it is that we need to find ways to support self-determination. Self-determination meaning how do young adults set and adapt to their short and long-term goals? How are they managing their resources? And how are they learning to balance their education, their work life, the emergence of their family, and community? And certainly, preparing oneself for opportunity is the most important thing, the most important driver of success, whether that's career success or success in health-related quality of life. A very, very central aspect, and when thinking about policies and procedures, something that is absolutely going to come up is consent and confidentiality. And we know that policies need to be rooted in ethics and in law, and that this is a way of respecting autonomy, and it can also be a way of engaging and learning together how to choose the other adults you're going to share your personal health info with, and who are you going to allow to be the influences in your healthcare decisions. It is the standard of care, and there's a large evidence base that shows that youth, adolescents, and young adults really identify this as a central characteristic of what is high-quality care. And certainly we know that we need to be very upfront about this. We need to have policies that are accessible to build trust, because we know if there is no trust, we're not going to know what's going on or be able to help our patients. But there are a lot of challenges for young adults, right? Because you have the right to confidentiality and you're considered a legal adult at your 18th birthday, that doesn't mean that you're ready to be independent and making healthcare decisions, particularly around coordinating care. And so that becomes often a very difficult place for office staff. The young adult says, my parents are going to schedule this, but they can't know certain things. And so that is it can be a minefield to walk when a parent calls and tries to change an appointment or asks a question. So again, it's again very important to have a policy that anticipates that young adults are going to need to define how their parents, what role their parents plays in their health care, and also that supports that changing over time, that anticipates that by the time the 18-year-old is 22, that parent is going to play a very, very different role. Again, thinking about the team-based interdisciplinary care requires constant communication between healthcare providers. And we know there's many platforms for this communication, everything from huddles to shared electronic health records to electronic sign-out systems. And so we need to utilize these so that there is a good exchange of information. And certainly recognizing and helping our patients understand that insurance companies are entitled to personal information, and understanding how to engage with the insurance company and manage your information is something that is very, very important to many young adults. And what we're doing is supporting this shared decision-making model, so that by the time of adulthood, most young and middle-aged adults, you're able to assume provider-patient confidentiality because they're driving the process of decision-making. They will on their own decide who they're going to share it with and collaborate with. But certainly most emerging young adults are in the middle here, where they're developmentally attuned to collaborate in the process, but the specifics around confidentiality and parent role are often negotiated and change very quickly over time. And certainly most teens should be invited to contribute to the process and included in the process in terms of preparing them for the collaborational role. When we think about this in terms of an office practice, we think about the team-based clinical care. We also think about the referrals that we're making, and so the community partnerships. Again, it's a very, very important to prepare the young adult for what to anticipate when making a referral. It's much more likely to happen, and follow-up is much more likely to happen if that occurs. And again, more broadly within communities, advocating for systems-level changes can be very, very helpful to help young adults, particularly in these vulnerable groups, access health care. So what is the sweet spot? What are the youth-centered outcomes that we're after? So certainly sustaining high-quality relationships with adult-oriented care providers that will serve their health throughout the life course. That is a beautiful thing, including development of self-management and wellness skills. And we know that this is rooted in stable employment, which is the foundation for our insurance system. That self-determination regarding work, health care, and relationships is an inherent right and should be afforded to everybody, regardless of health needs. And that community and civic participation lead to the meaningful changes that will improve our society. And so, in summary, we look at the components for effective health care for young adults that really begins with planning the longitudinal approach that spans transitions to adult-oriented care, support progressive transfer of decision-making from adults to individuals, look to create and strengthen opportunities to introduce and educate adult-oriented providers about the developmental needs of young adults, and engage youth to develop skills that will support self-advocacy and self-determination. I have included a couple of slides that talk about from a medical standpoint, what are some of the core services that we're hoping to engage young adults in that do lead to better outcomes throughout the life. So I list those there from the University of California, San Francisco. And finally, I wanted to highlight that opportunity is the catalyst for all of these outcomes. Certainly, the opportunity to fail and try again is the most important. And so the title of the talk, Post-Millennial Transition Blues, is a play on the subterranean homesick blues, which is actually about emerging young adulthood. So I included a verse here as well for some of the baby boomers in the audience. And so at this point, thank you again very much for your time and attention, and I'm going to hand it over to Megan Marmol, who will provide some comments.
Hello, yes, thank you, Dr. Pletcher, for the opportunity to speak and the PA Medical Home Initiative. As a young adult with a chronic health condition, I can relate to the transition challenges from pediatric to adult health care. And I want to reiterate the point that change is an inevitable part of life and something that we all encounter. And just like other cultures have a language, healthcare has its own complex language and imposes its own challenges. And it's important to note that transition is different for everyone. Everyone starts at a different point on the continuum. And it's important to identify the young person's abilities and work from there. It's a collaborative approach where providers, young people, and families come together to look at what are the goals that the young person has for themselves, both their healthcare needs, but then also holistically just in their life. And realizing that healthcare is of a different priority for each individual. And to consider the barriers outside of the healthcare setting, for example, transportation to and from appointments, and empowering young people to look at what do they need to set themselves up for success. For example, if they're in a wheelchair coming to an appointment, is the location of that appointment wheelchair accessible? Do they need an interpreter to have a meaningful conversation? And then realizing the transition process is daunting and requires both a plan and a team approach. And for some individuals, they might achieve complete independence at the end where the training wheels come off. For others, it might just be becoming educated in what their diagnosis is, and to start early in the adolescent years to allow for short and long-term goals and to make adjustments and adapt to the processes to see what works for that individual and what isn't, and where can we as individuals, as providers, as family members, empower young people to be accountable for themselves, but also realize that there are support systems in place that can help them, and where can they look to find such resources. And for providers, realizing that this conversation, although it may be difficult to have, it's important to start early, and also working with the families to realize that their young person will be making this transition, and how can family members begin to adapt the way they help their young person take control of their health care, whether it be making a list of their medications, how to schedule an appointment, how to pick up their medication and get refills, and realize what other resources are available, because this is a team approach, and without the young person at the center, the rest of the team members just fall to the background. So thank you, and now it's time for question and answers.
Hi, at this time we're going to open up to some questions. Thank you so much, Megan and Dr. Pletcher. To ask a question, you can type your question in the Q&A box, or if you're on the phone, you can dial *6 to unmute your line. Thank you. And Eileen, this is Dr. Turchi. I think it would be great if anyone had any questions for Dr. Pletcher or Megan, that would be great. And I know also our colleagues at the Epilepsy Foundation also were going to make some comments. So if I know you're moderating the questions, if there aren't any burning questions, we can allow them to speak as well. We have a question from Larissa. She asks, what efforts have been made with healthcare providers to change procedures for youth and the clients?
Oh, sorry, can you repeat the question for me?
Sure. The question is, what efforts have been made with healthcare providers to change procedures for clients that are youth?
Well, I can start by saying, procedures is a pretty broad area, but what comes to my mind is sensitive physical exams, which is often a huge source of anxiety for both clinicians and for young adults. For many, this may be the first time that they're experiencing such a sensitive exam without a parent present or without some other protective adult present. And so changes that are happening in policies around chaperones are happening very, very quickly, where the norm is becoming that having a chaperone present for a sensitive physical exam is really expected and anticipated for certainly at least that portion of the exam. And as folks are probably thinking, this has implications for staffing. This has implications for patient flow. But again, if you build a system starting with that assumption, it's definitely possible. And again, it results in better patient engagement and satisfaction. And it also helps clinicians feel better protected and safer in their environment as well. So I don't know if that example exactly applies to the question. I'm happy to, to address any clarification needed.
Thank you, Dr. Pletcher. Another question we have is, are there any tips for ways to handle teenagers who come late for well visits? We now have text reminders, but this still happens. We try to accommodate, but if we are busy, can't squeeze them in and not always able to help serve them. So do you have any suggestions regarding that?
Yeah, that's a great question for everybody. I mean, we're always open for good ideas around that. One thing that we've done that's had some success is breaking down the preventive health visit into discrete components and taking the components that require the physical presence of the individual and doing everything we can to make sure those happen when they do come, when they are in the office. So again, explaining to having a script available for staff to explain to the young adult that we're not going to be able to do everything we normally would do, and so we're going to change this. We're going to change things up a little bit, and we're just going to come in and we're going to go through, for example, the immunizations that you're due for. Again, this takes some planning. This takes it can be tied into quality improvement efforts around immunizations. You're hitting multiple wins with one fell swoop. And so you are able to provide the services that are there, and then perhaps some of the preventive guidance, some of the need for follow-up appointment can be scheduled to talk about things that might take a little bit more time. But a lot of the preventive education, anticipatory guidance can be provided online. And in fact, most young adults embrace that and prefer that sometimes than a face-to-face talk. So again, I think there are things we can do to break it apart. Again, anticipate those immediate needs and prioritize the things that have to get done when they're physically present, and then other pathways for the other parts.
That's great. We have another question, Dr. Pletcher. You mentioned that the young adults and the foster care system, due to being part of that system, has it been found to add extra barriers for these youth?
Well, yeah, I mean, I think there's really good, a lot of work is going into looking at the impact of not having access to health records, for example, not having the access to birth records, the past medical history, or family history, immunization records become disrupted, so it's a group of individuals are often under-immunized or misimmunized. And so, yeah, it certainly does play out because, again, not having that, there is no replacing a parent. Not having that continuous adult who's both managing and then transferring the management of your health history to you, things will become disrupted. And that's not even getting into all of the systems-related issues related to making appointments and dealing with insurance companies and so on.
That's great. Another question. What age is it suggested to take young adults to gynecologists, and does my daughter need to tell them herself at the visit she wants me in the room? Is there something to put into a file if a child still isn't mentally able to be in an appointment by themselves?
Mm-hmm. That's a great question. And I don't think there is a standard answer. I do believe and feel that the vast majority of primary care pediatricians embrace their role of introducing some of these concepts to teenagers, to parents, and then young teenagers about why is it important to take a sexual history and to have open communication about this, and when is it appropriate to begin screening for chlamydia and gonorrhea. And that conversation comes up with the HPV vaccine, certainly. So again, these are things that are inherent to what we do as primary care pediatricians. Individual needs might dictate referral or coordination with a gynecologist, and if available, a gynecologist who specializes or is specially training in pediatric and adolescent gynecology is certainly a very good thing. But I don't know or think that there is a one-size-fits-all standard age that should begin formal gynecologic exams.
Great. I think our colleagues, Ellie, were there any other questions at this time? I think our colleagues in the Epilepsy Foundation wanted to make a couple comments, Dr. Pletcher and Megan, if that's okay.
Not in our office.
Oh, really?
But she's not here. She's going to show it up there.
Great. Greg McConnell and Jordan?
If doctors can get him, I'll get him for medical help. I'll send her a text. Thank you.
Hi, this is Greg McConnell with the Epilepsy Association, and I just wanted to kind of elaborate on a couple things, and thank you so much, Dr. Pletcher and Megan, for such great information. One of the things I think as an association that works with a lot of youth with epilepsy, I think we do a good job at engaging youth. But one thing really stood out to me was I believe, from my perspective, we oftentimes have a tendency to kind of always reach out to those youth who are already so much involved with our services and our organization, and we don't tend to put a focus on reaching those who, as Dr. Pletcher said, who are underserved or uninvolved. So I think that was really key and so insightful for me. That was one point I wanted to make. And then the other thing was related to that kind of generational impact related to transition. And I think so much of the work that we often do is getting together, and we have all this great information, all these great ideas, and really well-respected people who are very knowledgeable in transition, healthcare transition, and other transition to post-secondary school, transition from high school to employment and so forth. But I think oftentimes, again, my perspective is we approach that from our old people, adult perspective, and so we may not take some of these generational differences that are very clear generational differences into account. So I just wanted to add some comments on both of those, and that was very insightful and helpful for me there.
I don't know if anybody else has any questions for Dr. Pletcher or Megan Marmol or Greg and Jordan at the Epilepsy Foundation.
Dr. Pletcher, how are you? This is Diego Chavez-Heneco from Pittsburgh. Thank you very much for a wonderful presentation. You clearly described in your presentation the demographic changes in the young adult population, and I wonder if you can comment about the need for cultural competent and linguistic competent healthcare for this new generation. You work here with us in Pittsburgh, you saw what we have here, but you also have the experience of working in Philadelphia and in Princeton, and I wonder if you can comment about the best way to deliver this healthcare in a cultural and linguistic competent manner. And again, thank you very much for a wonderful presentation.
Well, thank you. I really appreciate that. That's a fantastic question, and I would certainly a lot of people working very, very hard on this. I'd have to say that what I found to be particularly effective is a cultural sensitivity approach, trying to cultivate a culture where people are very, very open to different ideas and different ways of thinking. And there's multiple strategies to do that, and primarily rooted in exposure. And so this can play out in terms of recruitment. Certainly the onboarding process and training of staff and clinicians is really where this can greatly be implemented and highlighted by drawing direct connections between these values and how it plays out in improved work-life balance, teamwork, and ultimately patient satisfaction. And at the root of cultural sensitivity, and this also relates to gender and sexuality, is that critical self-reflection of internal biases and just slowly kind of like peeling an onion of taking away all of the assumptions that you make, both about yourself, how other people see you, and how you see and respond to other people. But it is, again, it's rooted in exposure and outreach and just really trying to listen. Far an adequate answer, but it's a really great question.
Thank you. Thank you very much. Any thoughts about the use of technology for interpreting services, for delivering materials, discharge summaries in the language of the patient?
Yeah, I know that's kind of like in its nascency. I really haven't, other folks may have more to say about that. I do think we have to get better at having educational materials written by the young adults who are in the community, who are of the people we're trying to serve, because it's language, it's culture, a lot of things get played out through the educational guide. So certainly having a review committee, or at least having someone take a look at it, whether it's in a language other than English or not, I think is extraordinarily important. Telemedicine is something that's rapidly evolving, and young adults, I know, are a target population for a lot of companies, because they do prefer on-demand service, and they do are quite good with technology. And so I do think there are ways we need to think about best practices around telemedicine as well.
Thank you very much.
Thank you.
This time it doesn't appear that we have any additional questions. Eileen, anyone else on the line have any other questions?
No, we do not.
Great. Well, I want to take a moment and thank Dr. Pletcher and Megan for their excellent presentation, and for our partners at the Epilepsy Association of Western and Central Pennsylvania for partnering with us on planning this webinar. And always encourage you, to go to all the various websites at our respective programs, as well as Got Transition for resources. I also want to acknowledge and thank the Pennsylvania Department of Health for the funding that made this webinar possible. And at this time, this concludes our webinar, and I want to thank everyone